Very important.
All right, so let's start. Gassan has a case for us, an unscripted case. Let's do a new report. Right, Gassan?
Okay. Because I want to learn more from it.
All right. Can you guys hear us downtown?
Yeah, perfect.
Okay, great. All right, so this is a case that's currently on the floor. Was admitted a few days ago. So I'm just gonna tell you the presenting symptoms, so the HPI briefly. So the reason for the admission is respiratory distress. So what we have basically is a 69-year-old gentleman with no significant past medical history, been healthy otherwise most of his life, and basically comes in because for the past few weeks, he's been kind of losing weight, poor appetite, some subjective fevers, shortness of breath, but then everything kind of got worse. 2 days prior to the admission, he started feeling a lot of shortness of breath and significant dyspnea on exertion. But the final reason that made him, so it sounds like a progressive worsening of breathing, but acute, there was an acute deterioration 3 to 4 hours before admission, that the patient felt that he was, drowning, that he couldn't breathe at all. So he called EMS and he was brought to the emergency room.
All right, so you said no past medical history, and you said shortness of breath, weight loss, loss of appetite for how long?
For a few weeks.
Few weeks.
Few weeks with a very sharp deterioration over the past week, and specifically over the past few hours prior to admission.
Okay. To worsen. Hours. Okay, so and no past medical history. So any give me a little bit more. Any surgical history, allergies, medications, just to.
No allergies.
Mm-hmm.
No surgical history. Never been hospitalized before. Does not take any medications.
Mm-hmm.
Healthy gentleman otherwise. Not a smoker. Does not drink alcohol. No drug use. He is a very, very smart person. Self-taught computer engineer. Very, very high IQ. Has a daughter that works in Houston for Chevron. Very famous. So very high functional status.
Okay, so very good. So for this gentleman, before we go into physical exam, anything else that you guys want to ask Gassan?
Few weeks.
So the question is when the symptoms started, right? So Gassan's answer is just a few weeks.
Yeah, so it's very gradual, like it's few weeks, but in retrospect, if you would question him more now, he would tell you maybe it's been a few months.
Okay.
And how much of weight loss?
We have questions
Very
from
subjective.
downtown.
Just a question here in West. This is Roberto. So you're saying that he's known not to have anything, but is he going to a doctor, or he hasn't been to a doctor in
No,
years?
he's been not connected. He did not follow up with any doctor because he considers himself healthy.
Okay.
Never seen a PCP in many, many years.
So not such a high IQ after all.
Yes.
Any sick contact recently?
No sick contact. Nobody has been sick around him. He had no URI symptoms whatsoever. No runny nose, no sore throat, no cough. No productive cough, I should say. No fevers.
Any night sweats?
Questionable. He did say sometimes he feels warm at night, but nothing too classic.
Any orthopnea, PND?
And
No.
also any dyspnea at rest or on exertion?
So leading up, like over the past few weeks, it's been progressive, worsening. But over the past week, definitely dyspnea at rest. And over the last 2 to 3 hours before admission, he just could not breathe at all.
Just want to clarify something with that, because that's a question that I hear a lot in morning reports. So I don't think there's a significant change in terms of like differential diagnosis when it comes to when the dyspnea is at rest or exertion. All dyspneas that are progressive start with being on exertion and then end up being at rest if the patient is getting worse, and that doesn't change the differential diagnosis. Now, the time course hyperacute, acute versus subacute or chronic is something that is more important when it comes to differential diagnosis. Right?
I would say it's acute on chronic.
Good.
Any orthopnea?
Acute on.
Sorry.
No hemoptysis, no orthopnea.
All right, I have a question. Now, this is a patient who comes in with a complaint that has actually changed in nature, right? So he has dyspnea from before, whatever nature that was, chronic, and now suddenly it's changed. It's important to spend some time in inquiring the time period around when it actually changed. I think that can give you a lot of clues. So my question to you would be, what happened when his dyspnea started getting worse? What was he doing? What time of the day it was?
I believe it was around the evening. He wasn't doing much. It was very sudden onset, very sudden deterioration in his breathing. No recent travel.
Josh wants to know if any colonoscopy is based on age-appropriate screening also.
No age-appropriate screening.
Just from the diagnostic reason standpoint, so one other thing to add here, so for you guys to ask more questions, is that we always like to have one single diagnosis that explains the patient's presentation. But we have a patient here that has some sort of like subacute to chronic symptoms with an acute, hyperacute worsening of one particular symptom, which is dyspnea. So it may be the case that all is explained by one diagnosis, but it may be the case that this patient has a subacute to chronic process, and then now on top of that has a different thing that leads to the hyperacute or acute worsening. So keep that in mind as well. And I would ask, you guys are asking great questions, but I would ask for risk factors for both chronic subacute conditions that can lead to dyspnea and for acute hyperacute conditions that can lead to worsening dyspnea. If that is a clue, I don't know.
They're asking if there's any change in vision or if there's any muscle weakness. The answer is no to both.
Okay, so that's a good thing because you are thinking about the possibility of a neuromuscular disease, for example, myasthenia gravis, Guillain-Barré syndrome, that can present with some sort of like subacute symptoms and then leading to something, a trigger that leading to an acute crisis and deterioration. So that's a great question. Okay?
The other unifying diagnosis in this patient, I would assume, is patient who's been having long-standing dyspnea and suddenly worsens. This could be a possible lung malignancy underneath, but he's a non-smoker given that, but a lung malignancy, maybe he like growing in size, so leading to a lung collapse, or even having the lung malignancy itself predisposing to a PE, even as acute presentation too. And these are things that's coming top of my mind right now.
I think that's a very, very good differential, and it's almost along the lines of what was the initial thought when he came in. No syncope. No chest pain. No chest pain. No, just shortness of breath. No significant family history. No sleep disorders.
Okay, what are the, so the main concern here is respiratory conditions. What are all the things that you ask people when you're concerned about the respiratory complaint in terms of things such as risk factors or exposures?
Did we already go over B symptoms? Fever, chills, night sweats?
I think they asked about fevers, and Gassan said that not
So-
clear, maybe warm.
Yeah, nothing, shouting as it's positive, but he did endorse feeling warm at night sometimes. He did say that maybe he's losing some weight, but nothing, objective. And he did say he feels warm at times, sometimes at night and sometimes during the day. No, nothing URI-like whatsoever.
Okay. So the question was if there were any sort of like vital symptoms or prodromes. The answer is no. Okay, so along the lines of pulmonary history, right? So you guys always ask about smoking history. But Avinash here is saying that smoking is not the only risk factor for pulmonary disease, and it's certainly not the only exposure that you can have, right? So we already asked about medications. The patient is not taking anything. You should also inquire about over-the-counter medications. So you should inquire about prior occupation and the possibility of exposures to fumes or dust and these kind of things. And you should also inquire about travel, either recently or remote. You know, you're also concerned not only about travel outside of the United States, but also within the United States to areas that may be endemic for certain infections or things like that. So, Gassan, if you can tell us about occupation.
I believe he works in an office.
An office. Okay.
No hazardous occupation that we're aware of.
Okay. No exposure to anything.
No travel. No.
No travel. We'll see. Is he originally from New York City?
I'm not sure, but he's from the States.
Okay. No exposure to the 9/11 thing or anything like that?
No.
Okay. So those are important questions that you have to be asking, right? So about exposures. And no recent travel within the United States either.
No.
Okay.
Does he have any pets? Sorry.
No pets.
Great. Like that. All right. Any other questions that you guys want to ask? All right. So anyone, does anyone want to kind of like have a initial summary of this case before we ask Gassan for the physical exam? Okay, remember our equation for the problem representation. So first, who is this patient? So what is his age group? Is he a child? Is he a teenager? Young adult? Is he middle-aged, elderly? So he's elderly, right? We have an elderly male. Okay, so what are his comorbidities and risk factors in context? Or no significant comorbidities, right? What are his risk factors? Were you guys able to identify any? Age, yeah, okay.
Elderly.
So, but nothing else so far. Okay, so with no past medical history or known risk factors, and he's presenting with, and here we have to try to identify what's the clinical symptom, right? So, and the timeline. So first of all, I'm going to say that he has with subacute to chronic, because it's unclear if it was weeks to months, so acute to chronic, dyspnea, as well as, and we can call these B symptoms, so we can just say, just like weight loss and failure to thrive, maybe. Weight loss, or failure to thrive. And you said the worsening was in hours or days?
Hours.
Hours.
Like
and
2 to 3 hours.
2 to 3
Acute
hours. So,
worsening.
and so we're going to say to hyperacute, just to hyperacute worsening dyspnea. So that is our first sort of like problem representation here. We cannot really say if this patient has, let's say, a respiratory failure now because we don't have O2 values or CO2 values. We're going to get that afterwards. We don't really get anything else because we haven't gotten the physical exam. So this is all we can say for now. I think at this point we want more data. We want the physical exam, right?
And just a plug-in, what ADIAC always tells us, this is our working assessment for now. But keep in mind that this might very quickly and very sharply change as more data comes in. All right, so let me tell.
Just going back to the idea of what dyspnea is. Dyspnea is not a clinical finding. It is a subjective, uncomfortable breathing that's reported by a patient. So it's not a physical exam finding that you'll find. You'll find tachypnea, you'll find orthopnea. These are clinical findings. but dyspnea per se is what the patient reports. So sometimes it can be also important to ask perhaps what exactly the patient means by dyspnea. Nobody comes in complaining of, I have dyspnea. So when the patient comes in, most of the times they're either short of breath, can't take a deep breath, or sometimes it's just associated with chest tightness. So if you spend 2 seconds asking exactly what the patient's feeling in terms of how uncomfortable or why he's uncomfortable breathing, you might also find some things like cardiac causes. If the patient has chest tightness, it's just, it's just being masqueraded by the fancy word that dyspnea is. So it's not a clinical finding, it's what the patient is reporting.
All right.
Very good.
So in terms of his vitals, initially in the ED, so when he was brought in by the EMS, he was already on oxygen when he arrived on a non-rebreather mask. So in the ED, the initial set of vitals, so he was tachypnic, 25. He was tachycardic. The highest initially was 150. He was afebrile, and on 5 liters non-rebreather, he was saturating at 99%.
So did EMS say how what was his saturation when they arrived at this?
Unclear.
Not clear. Rebreather, and it was 99% of this. Okay.
However, so I'm going to tell you a little bit more about the physical exam. So when the patient was initially seen, he seemed to be in acute distress. He was working very hard to breathe. Accessory muscle use. Seemed, in distress. So more specifically on lung exam, you could appreciate very loud crackles bilaterally up to the mid-lung fields. Cardiac exam, he was tachycardic, regular rate and rhythm at 150. Abdominal exam was soft, non-tender. He was warm and well perfused. There was no lower extremity edema. Yeah, that's an important point. There was no lower extremity edema. Blood pressure was 140/90.
And can you tell us about the JVD? That's, I think, is important, right?
Yeah, there was no JVD appreciated. No, nothing significant.
Okay. So,
And you said his extremities were warm, well perfused, no
Warm.
signs of shock, no capillary leaf, it was normal.
Yeah, warm and well perfused, and yeah.
Mentating well also.
Say that again.
Mentating well.
Mentating well. Yeah.
Michelle is asking about lymphadenopathy.
Okay.
Does he have any clubbing?
No clubbing.
No lymphadenopathy?
So that's a great question. So when I would see this patient right off the bat, lymphadenopathy would be the least of my concerns, right? That's just me. But yes, he did have lymphadenopathy. So he had bilateral axillary lymphadenopathy. I can say multiple lymph nodes appreciated in the axilla, let's say 1 to 2 centimeters in the bilateral axilla.
that's good. So we have a good physical exam in here. So I think we can try. So you guys see that I labeled this number 1. As Gassan said, this will evolve. So I think at this point we have to kind of like have our second problem representation here. And I say that we need to somehow add our physical exam findings. So continues to be elderly male with no past medical history or known risk factors, presenting with subacute chronic dyspnea, as well as weight loss, failure to thrive, and hyperacute worsening dyspnea. With, I think the important thing here is that the patient has bilateral crackles up to the mid-lung fields, and has tachycardia, and has these lymphadenopathies that we don't know if it's related to the presentation or not. Okay, so sort of like our second problem representation. So at this stage, I think one important thing to consider here is that whenever you see a patient like this, you must act and manage the patient before you embark in any diagnostic dilemma here, right? So you make sure that your ABCs are done, and after your patient is stable and you have taken care of your patient's oxygenation and ventilation, and circulation, then you move on to the next step, which is trying to find out what's going on. Now, I think it's a good moment to sort of like stop and try to think about a framework for dyspnea, right? So, does any one of you have a framework for dyspnea? Diagnostic framework? Yeah, so you want to grab the microphone?
I mean, when you think about dyspnea, there's the dyspnea pyramid, which is based on the base rate, and at the bottom of it, you have pulmonary as well as cardiac causes, which is most common just based on the prevalence of it. And then we can go down further that, but other non-cardiac and non-pulmonary causes will also include metabolic acidosis. You will also have like neuromuscular dysfunction. You can have anemia too. And then if you think about respiratory and cardiovascular causes, you can think about it anatomically. So cardiac causes, you can think about the myocardium, where you have heart failure, you have valvular pathologies, you have ACS, you have arrhythmias, you also have pericardial effusion, and then respiratory causes, again, anatomically, just like Adiak is drawing, you have the lung parenchyma, you can think about the pleural causes, and then the also like obstruction. Yeah, that's basically the small framework.
That's great. I think the framework for dyspnea is at least it's better divided into respiratory, cardiovascular, and something else, right? So respiratory and cardiovascular for dyspnea is always purely a type of anatomical framework. If you follow all the structures in both the heart and major vessels and the lungs, you can kind of come up with all the possible causes of dyspnea. For example, for respiratory, you can have stuff in the upper airway, you can have the stuff in the trachea, major bronchi, you can have a small airway disease, you can have processes that are interstitial in nature, you can have alveolar filling disorders, you can have pleural issues, anything that is affecting the pleura, and you can have things that are even outside of that affecting the chest wall, right? And we can sort of like further divide even those stuff even more. Then cardiovascular, the same thing. If you go anatomically, you can say that you can have pericardial problems, you can have epicardial issues, and that I would include the coronary arteries. You can have myocardial problems, you can have endocardial issues, and that would include, of course, like things such as infectious endocarditis, things of that sort, and valvular problems as well. And then you talk about the major vessels, right? So major vessels also be included in this problem. So that's cardiovascular. And then miscellaneous, as Amish was mentioning, some of the most common causes are anemia, metabolic problems, and you know, the metabolic problems you are going to talk about, of course, metabolic acidosis is one of the main things in here. And there are some others, but I think these are the things that we see the most. Now, remember that when we are coming up with the differential diagnosis, the three things that you need to look at are, number one is never miss diagnosis. So what can kill your patient right away? What is your working diagnosis? So that means what is that entity that most likely explains the patient's presentation, and is usually a common disease, right? And then you are going to think about alternate diagnosis, and these are usually 2 or 3 conditions that are usually common diseases that can also explain the patient's presentation. All right. So what are never missed diagnoses in a patient presenting with hyperacute dyspnea, especially on a, sort of like a subacute chronic, acute and chronic dyspnea? I think Amish mentioned the possibility of a PE. And this is, you have a theory, and it's important to try to explain in your mind what could have happened, right? So maybe the patient has some sort of like chronic, subacute chronic conditions, such as cancer, either primary lung cancer or metastatic lung cancer, leading to, you know, hypercoagulable state, and that by itself led to a PE, and that explains the hyperacute presentation. So definitely one thing that you need to think about, particularly when this patient that is also very tachycardic, etc. So that's one possible never misdiagnosis that you need to make sure you think about if you can rule it out initially, right? So what else is a never misdiagnosis for acute dyspnea? The pneumothorax.
But keep in mind the physical exam findings.
Yeah. So pneumothorax, and we're gonna put the never misdiagnosis in here. Then we're gonna contrast that to our coronary representation and our findings afterwards. So as Gassan was saying, so against the pneumothorax is the fact that the physical exam doesn't really suggest pneumothorax, right? What are the physical exams, the physical exam findings of a pneumothorax?
Decreased breath sounds, and then if it's really big, you can have compression and you can have compression of the other side. So you can have shifting of your trachea. You can have hypertension if it's flowing, and then on percussion of there'll be high resonance rather than the tympanic percussion. You'll have hyper resonance, and I mean, what else?
I think you can just think about this in a continuum, right? From pneumothorax, non-complicated, let's call it, where you will have a patient with acute pleuritic chest pain, which a patient didn't have initially. I think chest pain is probably the most striking symptom of anyone with a pneumothorax, right? So the fact that the patient did not have chest pain kind of already puts this very low in the differential. In the physical exam by itself, you will have decreased breath sounds, and then as the pneumothorax becomes bigger and progresses to tension pneumothorax, you can have all of the findings of an obstructive type of shock, right? So very good. All right, so what else is a never miss here?
ARDS or pulmonary edema.
Well, you're gonna say that we're gonna call this pulmonary edema. And then you can have cardiogenic or non-cardiogenic. Okay. And then cardiogenic. Now, you have to contrast this to your physical exam. Does the physical exam suggest cardiogenic pulmonary edema?
There's no JVD. There's no sign to suggest congestion currently on the physical exam, except for bilateral crept. So you would think more towards ARDS. How an acute heart, like a mitral regurg or anything, you can still have that.
Yeah.
But
So I think so. The fact that the jugular venous pressure is normal, and there's no JVD, and in someone who already has a subacute to chronic presentation with hyperacute now worsening, even though the bilateral crackles make you think about cardiogenic pulmonary edema, I think it's lower in the differential for me. Although you keep it in the back of your mind for something else. But I will say that, again, no jugular venous distension, no other signs of increased central venous pressure. Non-cardiogenic pulmonary edema, of course, is very high in the differential. What can cause non-cardiogenic pulmonary edema? So the one thing that comes to our mind is ARDS. Now, ARDS, remember, that has to have a trigger, right? And the question is, has this patient had any trigger for possible ARDS? And so number one, I'm going to ask you, so what are the three more common things that lead to ARDS?
sepsis, aspiration,
Burns.
and then inhalation.
So
Most common.
three are pneumonia,
Yeah.
right? Aspiration and sepsis. So those are the three things that most commonly lead to ARDS, although there's a long list of things that can lead to ARDS. This patient doesn't seem to have any of those. And the other thing is, remember, according to the Berlin definition, this stuff must have happened within 7 days. So I don't know. I don't see anything of these in the presentation, although we may be surprised. Now, if you have ARDS type of picture without any trigger, what do you call that? It's definitely one of the interstitial pneumonia, on the idiopathic interstitial pneumonias, but how do you call that? So ARDS without a trigger. That's acute interstitial pneumonia, right? Hammond-Rich syndrome. That's rare, so we're not going to call that. However, when the patient has bilateral crackles, so crackles usually mean, so either the patient has an alveolar fluid disorder, if this is all acute, or the patient has a chronic fibrosis with some sort of worsening acutely, right? So if we're going to talk about alveolar filling disorders, so what can fill the alveoli? And that's the other question, right? Because if you have these, and if we confirm this with imaging, then the differential diagnosis is all about this, about what can fill the alveoli. So we already say that water or fluid
Blood
and
pus and fluid.
huh?
Blood pus and fluid.
Blood. So if you have diffuse alveolar hemorrhage, for example, and water, we say cardiogenic and non-cardiogenic pulmonary edema. What else can fill the alveoli? So pus, and that will be pneumonia. Okay. What else? We're going to call cells, and we're going to do this tumor. And, you can have, lymphatic spread of tumor, bronchoalveolar spread of tumor, and in a patient with very advanced cancer leading to this type of picture. And you can have actually some mucinous bronchial carcinomas that secrete mucin, and that can also fill the alveoli. And it's actually considered one of the alveolar filling disorders. So mucin, so we're going to call this in here. You can have protein in how do you call that? Alveolar proteinosis. Okay, what else can fill the alveoli? I think we have pretty much most of the things that can fill the alveoli. So this is the differential. So what you want to do here is that after this physical exam, you want to make sure that you rule out your PE. To rule out your PE, initially you calculate what's your pre-test probability, right? And based on that, you decide what are you going to do. So what is the pre-test probability for this patient? What is the Wells score? I think it's probably intermediate risk, right? There doesn't have any mobilization that we know. There is some things that can explain the presentation as likely, has only tachycardia. Moderate, yeah, intermediate risk. For intermediate risk, what is your next thing?
Do a D-dimer.
Yeah, so you can send a D-dimer. If this is high, you're gonna go ahead and test the patient with the CT angiography. If it is negative, then most likely there's no PE in this. So this is one route. Pneumothorax is very unlikely based on a physical exam, but we're going to get a chest X-ray anyway on this patient. And then getting a chest X-ray will help us out to see if this patient has or doesn't have some sort of like possible alveolar filling disorder. So what do you guys want to get in this patient in terms of workup?
Tell me everything you want, and then I'll sort of give you everything, so you have all the data.
I just want to point out about the Wells score. Usually, Wells score has been actually validated only in outpatient settings, and when it was actually checked in inpatient settings, it did not fare that great. So it's basically a clinical judgment, even though we take Wells criteria.
This is a patient presenting to the emergency room, right? So this is like this is not a patient in the hospital. Hospital, this is someone coming to the emergency room.
But again, that was outpatient, not outpatient, right?
It's technically that the actual scenario where you use it, right? So outpatient, purely outpatient. What do you mean? Is this what you're trying to say is that for someone who is admitted to the hospital for 2 days with a different thing, that patient is a different story. But this is someone that is technically outpatient. He's coming to the ER. So this is where you have to, upon that presentation, you do calculate your pretest probability based on your Wells score. Okay? So you want to get a I think getting a CBC is reasonable. So maybe the patient has infection. You want to see if WBC is high. You want to see if there are severe anemia. So those stuff are reasonable. Getting a BMP, I think, is reasonable because you're going to see if the patient has a AKI, for example, which is quite important. You're going to get that. You want to get
VBG.
the D-dimer. ABG, right? I think will be indicated here. Would you get a BNP, natriuretic peptide?
Yeah.
I think it's a good thing to get in this setting because it's equivocal, right? The patient has cardiogenic or not. I mean, if the central venous pressure is elevated here. You want to get an EKG, of course, because if the patient is in, I don't know, like a V-tach with pulse, well, that explains pretty much everything, right? So what else do you want to get?
Wes says HIV and flu swab and bedside ultrasound.
So great. So I think after you get the chest X-ray, and if you say that the patient has some sort of like presentation that may be suggestive of, let's say, PJP pneumonia, for example, that's a great thought. Of course, getting an HIV is important, HIV test. And point of care ultrasound, that'll help a lot if you know how to do it. What else did you guys say?
A flu swab.
Blood culture.
A flu swab. I think for everybody presenting with respiratory symptoms in this time of the year, we should be getting this stuff. However, this patient did not really have a presentation that is consistent with influenza. Although again, for this time of the year, the pretest probability is probably high for everybody presenting with acute dyspnea or with respiratory symptoms. Okay, you want to give us this?
Yes. Let's start with the D-dimer.
Okay.
He was obviously, we didn't draw labs first on this patient. So the first thing that we got is the EKG and the chest X-ray. So I can tell you those first. So the EKG showed a flutter. Okay. That was the main thing on the EKG.
And what was the heart rate on the EKG?
150.
150, okay.
With no ST or T wave changes.
Okay.
The chest X-ray, and I will tell you exactly how they read it as. Basically, it was bilateral pulmonary edema. So initially read as...
So let me say something, and this is, Avinash and I were reading the Fleischner Society terminology for reading chest X-ray and stuff like that the other day, and that term is discouraged, right? You should use the term opacities, because you don't know if this is really water or something else. So saying based on the chest X-ray that is edema is probably not the right thing to say. But I would say bilateral opacities.
Yeah. So let me read the official read. Moderate pulmonary vascular congestion with interstitial edema consistent with moderate pulmonary edema.
All right, so vascular congestion you can say, because you can say that the patient has redistribution of the vasculature, so that you can say. Bilateral interstitial opacities, and you can call these either ground glass or consolidation, remember, depending on what it is, but that you can say. All right. Then you can give us the rest of the stuff?
Yeah, so the D-dimer was elevated. It was like 3.
Okay. H adjusted was high still, right?
Yeah, it was high. It was positive. And then in terms of the other labs, they did the VBG. They didn't do an ABG.
Okay.
Then the blood gas showed a pH of 7.25. CO2 was 50. And bicarb on that one was 21, if that's relevant.
Okay.
They did a troponin right away. That was elevated at 0.25.
Okay.
Then your labs, so CBC, it showed a hemoglobin of 13.6
Okay.
with an MCV of 103, if that's important. White count was normal at 4.2, slightly low, actually. Platelets were 141. That's basically, and no left shift on your diff.
BNP, natriuretic peptide, did they do?
Yes, they did. It was elevated. Let me tell you exactly what it was. It was like 300, I believe. Yeah, it was elevated at 300.
So now, Gassan, with this finding, so number one thing that we're questioning is that did the patient really have JVD or not? initially.
Maybe he did, maybe he didn't. Our exam,
So
he didn't.
I'm sorry, we had to question your physical exam.
Absolutely. So it's not my physical exam, but
I know, no, I'm just joking. No, but that's
yes, yes, a very good thought.
okay. So did anyone focus the patient?
BNP was 313.
Okay.
I don't know if he was focused.
Okay. So any thoughts on this, these findings? I think that, and what Frida is here saying is that the EKG being on a flutter sort of like gives her to believe that this is cardiogenic in etiology. It might go either way. You know, if you have an acute disease with severe respiratory distress, the patient can go in AFib, a flutter. They can do weird stuff. So that's not entirely true. However, I will say that with these findings, cardiogenic pulmonary edema goes up in the differential again, because now the patient has elevated natriuretic peptide, has a little bit of troponin leak. The chest X-ray is suggestive of pulmonary vascular congestion as well as bilateral opacities that could suggest cardiogenic pulmonary edema. So that is definitely in the differential now again.
So Adiak, here I'm David downtown. Quick question: do we have a previous TTE on the patient? Because it probably, if
No.
the patient had a prior HFpEF diagnosis, or maybe he didn't have the diagnosis, but he has HFpEF, what may have happened is he lost the atrial kick with the flutter and trigger this whole exacerbation of the HFpEF or
Yes.
pulmonary edema, however you want to call it. So I think that's a very good working diagnosis. But I think a TTE or even just a POCUS looking at the ventricle function would be very useful now.
Yeah, and another explanation when David on the same line is that maybe the patient had tachycardia based on this flutter for quite a couple of days or weeks and developed tachycardia-induced cardiomyopathy leading to this acute presentation. So that's definitely something else you need to think about. So I think after seeing these pieces of data, cardiogenic pulmonary edema will be my differential, and topping the differential. I think you can probably proceed to treat this patient. If I was in the ED and I had this data, I would be giving Lasix to this patient, right? And I would probably put this patient on BiPAP as well, or CPAP, some sort of like non-invasive positive pressure ventilation in here, because that'll help. And at the same time, I will get a TTE to see, what is the what's the heart doing right now. Now, the thing with this stuff is that regardless of the D-dimer, because of the chest X-ray showing these, I think we now have a very clear explanation of what is going on. It's something filling the alveoli. If the patient had a normal chest X-ray and nothing filling the alveoli, I would probably be thinking along the lines of PE. But I think now that goes to lowering the differential, and we can work up what the positive findings that we have. So do we have a TTE on this patient?
We do. But let me tell you the CT first, because they initially felt that it was a PE. That was the working diagnosis in the ED initially. So with the positive D-dimer, he got a CT.
Okay.
Do you want me to tell you what they did before that in terms of initial management, or you want?
No.
to speed
Give
up?
me the CT.
CT. Okay. So let me read that for you, because so there was no PE.
Of course.
The first thing to tell you. All right. So basically, what they found on the CT was there was no pulmonary embolism, but then there was a massive subcarinal mass. It was 7 centimeters by 4 centimeters. So that was one finding under the subcarina, in the mediastinum. They also found multiple lymphadenopathy in the abdomen, measuring up to 2 centimeters. Then they read probable lymphanginic carcinomatosis concerning for malignancy, follow up with PET scan. They found some pulmonary nodules, one measuring up to 1.2 centimeters. And then they also found bilateral axillary lymphadenopathy.
So let me, again, going back to what we were talking about the Flexion Society definition stuff. So by reading the CT scan, you can suggest diagnosis, but if you're saying that this is lymphatic spread of carcinoma, it's probably not the right way to say it, because there are other things that can have a similar presentation, right? So most likely this patient in the CT scan had a nodular pattern of sort of like hyper-attenuating lesions with a lymphadenopathy distribution, and that can be definitely can be a cancer, but can also be many other things, including sarcoid and something else. So, so lymphadenopathic pattern of nodular, whatever we're going to call this, and okay, so that's in the CT scan. So
Let me tell you the echo.
uh-huh.
So the echo showed global hypokinesia with an EF of 40% with a dilated RV. No ball motion abnormalities. And the other thing was there was moderate, well, initially read as severe pulmonary hypertension with an estimated pulmonary atrial pressure of 70. But then later on that, on a repeat echo, it was lower. Just FYI.
Oh, but that's probably,
That was acute.
that was probably a group 2 type of pulmonary hypertension, because probably you gave diuretics to this patient and the LV sort of like
Exactly.
pressures decrease, and that's why the pulmonary pressures decrease. So if you guys, because in the interest of time, if you guys were to give a hypothesis of what's going on with this patient before Gassan gives us the final thing, what do you guys think is going on? One or two hypotheses.
For what's going on with the patient?
What's going on with this patient, yeah. Let's say hypothesis number 1.
So I think because this patient presented hyperacutely, he developed like an acute pulmonary edema that was triggered probably by this new arrhythmia. And it's possible that the mass was compressing the left atrium, which triggered this arrhythmia.
Right, so I'm going to try to give this in a cause-effect type of thing. So cardiogenic pulmonary edema led to the final decompensation. Before that, we have atrial flutter. And then after that, we have tachycardia-induced cardiomyopathy. And then you say that there is a mass in here that could have led to compression of the left atrium.
Yeah, triggering the arrhythmia.
Okay, maybe. Or maybe something else that the mass caused that led to all of these. But yeah, that's a good hypothesis for presentation. Any other hypothesis?
Remember, there was multiple lymphadenopathy. There's this mass in the mediastinum. There's weight loss. There's subacute on chronic shortness of breath. And then there's this acute decompensation.
So what you're saying is that the mass on the cancer has a high burden of disease, causing hypermetabolic state, probably patient not taking, PO intake, whatever, leading to tachycardia, then tachycardia leading to tachycardia-induced cardiomyopathy. Okay, so that's good. So what else? Other hypotheses? So can cancer itself explain all of these?
Subcarinal.
Which can infiltrate the heart
So at West here, we say that another possible hypothesis is that the subcarinal mass may have infiltrated the heart. Is that right?
Yeah, so it could have infiltrated the pericardium, and you're saying that probably led to some sort of like pericardial metastases and probably constrictive pericarditis, although the physical exam doesn't show anything of that, nor does the TTE. So that's another hypothesis. Yeah.
The other question here is, if it's a flutter, what kind of flutter is it? The typical A flutter is, as you know, is a re-entry circuit around the cavot tricuspid isthmus, which there should be a trigger for it. Usually it's not malignancy causing a re-entry circuit around the cavot tricuspid isthmus. So I don't know what the answer to that is, but I'm wondering what that is, and if that could have actually played a role in that too.
So if it's a typical flutter, what you're saying, probably the patient had the underlying re-entrant circuit, and then all of this was triggered in the setting of a secondary disease. Or maybe it's just a typical flutter, and there are some other things in it. So we don't know, but good. So the possibility of cancer only causing this disease, you can probably have pretty much lymphangitic spread of carcinoma, maybe mucinous adenocarcinoma leading to an alveolar filling disorder, and that would have led to the worsening. And maybe the atrial flutter led to also cardiogenic pulmonary edema. You have two conditions causing the same presentation. That's another thing that you can, another hypothesis here. And
another hypothesis, just to add, sorry, Bin, just to add it, that this can also all be cardiac in origin too. Maybe he just has CHF that we didn't know about, triggering the arrhythmias, triggering the edema in the lungs.
Yeah.
Or maybe like an ACS in the future.
Absolutely. Absolutely. And then the possibility of subacute to chronic infections, you cannot rule out because they can also present with all of these lymph nodes and sort of like this micronodular pattern with a lymphagitic type of pattern. And that would include like miliary TB, things like histoplasma, things like that. But that's not very common in the United States, so it will be very, very low in the country. All right, so in the interest of time, Gassan, tell us what happened with this patient.
So very, very briefly.
No.
In the ED, he was placed on BiPAP, and then he was given IV metoprolol to control the rate and started an oral metoprolol and given Lasix. And very quickly, the patient improved. Then he was brought to the floors. In light of that, finding this mass, the working diagnosis was, or the main concern was, cancer with mets to the lungs or to the lymph nodes versus lymphoma. As you know, when the echo came in, there was, cardiology was consulted, troponin peaked. There was a concern for either an infiltrative kind of cardiac disease leading to the arrhythmia versus arrhythmia-induced cardiomyopathy. So the fact that that patient was African-American as well, and the fact that there was this diffuse lymph node, sarcoid, jumped into the differential. So then we wanted to do an EBUS, so an endoscopic biopsy with ultrasound. The procedure was aborted because the patient again went into pulmonary edema. He started also having multiple runs of non-sustained VTAC on the tele. That made cardiology more concerned, so that stopped the entire pulmonary workup, and we went down the cardiology workup. He got a cardiac MRI. The study was aborted in the middle because, again, he went into flash pulmonary edema. But the study was read, and it's consistent with cardiac sarcoid. And now the patient is planned for a biopsy, this coronal mass biopsy. But we already started the patient empirically on prednisone because we're almost convinced that this is going to be sarcoid.
And that brings me again back to what we were talking about, using the right terms. So the reading of the CT saying lymphangitic spread of carcinoma is not the right way to put it.
Actually, specifically on that point, with Dr. O'Sullivan, when she read that CT, she was very upset because she said, this is very misleading.
Exactly.
And she was like, this should have not been included in the report.
And that's why what I was telling you, if you say that this is a nodular pattern with the lymphangitic, it's a nodular opacity with the lymphangitic pattern, all of a sudden, all of this stuff come back to the differential, including sarcoidosis, which is atypically can present with that, including the lymph nodes. So that's why this is very important, to use the right terms. Because essentially, the term that was used by reading the CT scan led everybody to be anchored on the possibility of cancer, then possibly missing actually the right diagnosis. So,
and the final piece of the work, the management, is that once he gets the biopsy, the EP is planning to do an ablation because they feel there is potentially an ablatable, circuit.
Absolutely, and that also answers Amish's question. So essentially, the patient can have an infiltrative disorder, particularly sarcoid, leading to the anatomical base for the reentrant circuit, which typically causes a flutter. Very good, great case. Any questions about Gassan?
Questions?
Okay, thank you guys.
No questions. Thank you. Thank you, Gassan.